Prashant.
Yes. Madam, I'll go ahead. Huh?
Yeah. This change.
Hello, good evening.
Listening. Just wait for a while. How to change the slide?
No, madam, what you do is that I will run the slides. You just speak on the slides. Huh? No problem. Yes, you just comment on the slides.
Okay. No problem.
Yeah. Good evening, doctors. Welcome to this experience sharing program on management of PPH. Today we have got Honorable Speaker Dr. Tanya with us. Welcome, madam. This program is brought to by Hetero Healthcare. Hetero Healthcare, has got 25 years of excellence with 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally and we are among the largest manufacturers of ARV, APIs and FTFs in the world. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India, wide product range encompassing multiple specialties and pioneering in quality and innovation. We have distinction of bringing 4 biosimilar products to market within 5 years of initiation. This experience sharing program on management of PPH, as I said, today we have got Honorable Speaker Dr. Tanya Priya with us. Dr. Tanya Priya is MBBS DGO MD Gold Medalist, all from Darbhanga Medical College and Hospital, Leher Sarai, practicing in Ranchi since 2017, posted as gynecologist in Sadar Hospital, Ranchi since 2018. Once again, a warm welcome, madam, and I'll start off the session. Over to you.
Thank you so much. Good evening to all my seniors and my colleagues. It is my great pleasure and honor to welcome you all today. We kindly invite you all to the experience sharing program on managing PPH. I'm sharing some slides on overview of postpartum hemorrhage. PPH is loss of at least 500 ml blood following vaginal delivery and 1000 ml following cesarean section. PPH is common and can occur even in women who are not at risk. PPH is the leading cause of maternal mortality in low-income countries and the primary cause of nearly 1/4 of all maternal deaths globally. Now, postpartum hemorrhage, it's unfortunate yet common. Maternal mortality, leading cause of maternal mortality, accounting for about 35% of all maternal deaths. MMR is developing countries was 240 per 1 lakh live births compared to 16 in developed countries. The global PPH incidence, 14 million women suffer from PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. 38% PPH incidence in India, 38% of maternal deaths are due to PPH. 25.7% of global deaths take place in India, and 2/3 of these attributes to PPH. India has an unexpected high maternal death rates, 540 per 1 lakh live births. Now, etiology of the PPH, tone, uterine atony, inability of the uterus to contract, which may lead to continuous bleeding. Thrombin, coagulopathies, failure in clotting, and trauma, uterine trauma, injury to birth canal, rupture and uterine inversion and laceration, and due to some tissue like retention of placenta and clots and abnormal placenta. Now, clinical findings in PPH, abdominal tenderness, circulatory collapse, increasing abdominal girth, loss of uterine contraction, maternal tachycardia, and vaginal bleeding. And the degree of shocks are done in the like mild, moderate, and severe. We see the clinical features and then we assign the degree of the PPH. Now, diagnosis of the postpartum hemorrhage, initial evaluation, rapid assessment of patient's status, presence of tachycardia and hypertension, assessment of vital signs and blood loss, examination at the time of hemorrhage, assessment of the entire genital tract for laceration, hematomas, or sign of uterine rupture, manual examination for retained placental tissue, assessment with bedside ultrasound to check if the uterus is not contracted, evaluation of uterus to check for uterine inversion. Now, laboratory assessment, complete blood count to check hemoglobin, hematocrit, and platelets, coagulation studies, and assessment of fibrinogen. Approach towards the postpartum hemorrhage. Now, attempt should be made to identify the cause in women, who are bleeding in parallel with resuscitation, like poor uterine tone, clinical findings at abdominal palpation and uterine fundus, investigation, full blood count, coagulation profile, urea electrolytes, abdominal ultrasound. Then for when we come for management, uterotonic agents like oxytocins, prostaglandins, and ergot alkaloids, uterine tamponade, and hemostasis algorithm. Other than surgical measures we all take, that is. Then the trauma or tears, clinical finding like bleeding of the trauma with genital tract, uterine rupture, extension of uterine angles, tear during cesarean section, yeah, extragenital causes. Now we come to investigation, inspection during cesarean section or ultrasound, and then management, repair of identified genital tract trauma, pelvic arterial embolization. Then there may be a retained tissue, clinical findings, retained tissue and membranes identified during my bimanual examination, investigations can be done under anesthesia, and management of the retained placenta is to remove it manually or under anesthesia. Then comes coagulopathy, clinical findings, continuous bleeding and contracted uterus. In coagulopathy, there is continuous bleeding, but uterus may be contracted. Investigation, urea and electrolytes, full blood count, coagulation profile. Then we come to management, immediate replacement of blood and surgical managements. Rationale of development of carbetocin in new heat stable formulation. Oxytocin and ergot alkaloids should be kept in a refrigerator to avoid degradation. Now our carbetocin is room stable at room temperature. Heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should be stored at 2 to 8 degrees C, and resource poor countries do not always have cold chain transport and storage capability. In our carbetocin, it is stable at room temperature, has shelf life of 24 months at 30 degrees C and 75% humidity, avoids the need of cold chain storage and logistic. It is provided in a vial. Use of urotonic agents, time of administration, at the crowning of the baby's head, at delivery of anterior shoulder, at the end of the second stage of labor, following the delivery of placenta. Prophylactically, we can use in the prevention of PPH, active management of the third stage of labor, and in therapeutic we can use in management of PPH. What molecules we use generally are oxytocin, carbetocin, ergometrin, symptometrin, and misoprostol. Often. Carbetocin, a next generation drug for PPH management. It is a synthetic, long acting analog of oxytocin. Therapeutic indication, prevention of postpartum hemorrhage due to uterine atony and facility. Its administration, one vial contain 100 mcg per ml. Carbetocin in 1 ml solution injection. Carbetocin has created Carbetocin has created by making several modifications to the oxytocin structure, prolongs half-life, reduces enzymatic degradation. Clinical evidence, efficacy and safety of carbetocin. Okay, oxytocin in versus carbetocin. Oxytocin is a synthetic cyclical peptide form of the naturally occurring posterior pituitary hormone. It binds to oxytocin receptor in the uterine myometrium, stimulating contraction of this uterine smooth muscle by increasing the sodium permeability to the uterine myofibrils. Intravenous, almost immediate action with peak concentration after 30 minutes. IM, if given IM, slower onset of action, taking 3 to 7 minutes, but produces a long lasting clinical effects up to 60 minutes. Half life is 1 to 6 minutes and requires protection from light and storage at 2 to 8 degrees continuously to preserve its activity. And in versus carbetocin, it is a long-acting synthetic analog of oxytocin with agonistic properties, binds to oxytocin receptor in the uterine muscle, smooth muscle, resulting in rhythmic contraction, increased frequency of existing contraction, and increased uterine tone. When given in IV, sustained uterine contraction within 2 minutes, lasting for about 6 minutes, and followed by rhythmic contraction for 60 minutes. When given IM, sustained uterine contraction lasting for about 11 minutes and rhythmic contraction for 120 minutes. Its half-life is 40 minutes. It can be stored up to 30 degrees C. It is heat stable, and it can be used. It is mainly used in prevention of PPH. Either oxytocin can be used in augmentation of labor, induction of labor, prevention of PPH, and treatment of PPH. But this is specially designed for the prevention of PPH. Carbetocin non-inferior to oxytocin. Various studies are there. Okay. Primary outcomes: the proportion of the woman with blood loss of at least 500 ml or the use of additional uterotonic agents. The proportion of the woman with loss of at least 1000 ml, blood of at least 1000 ml. The frequency of blood loss at, of at least 500 ml or the use of additional uterotonics agent with carbetocin was proven to be non-inferior versus oxytocin. The use of additional uterotonic agents, intervention to stop bleeding, and adverse effect did not differ significantly between the two groups. The conclusion: carbetocin was non-inferior to oxytocin in prevention of the blood loss of at least 500 ml or 1000 additional uterotonic agents. Cochrane review: Carbetocin for prevention of postpartum hemorrhage. In this Cochrane review data, 11 studies involved 2,635 women were included, and the author concluded that for the women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to syngometrin in prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. The guidelines recognize the benefits of carbetocin for preventing uterine atony. According to WHO, the guidelines for the PPH prophylaxis, only one of the following: oxytocin, carbetocin, mesoprost, ergometrin or methyl ergometrin, oxytocin and ergometrin, fixed dose combination. SOGC Canada, according to SOGC Canada, carbetocin 100 UG IV bolus. Ranjog, New Zealand in 2017, active management of the third stage of labor, prophylactic uterotonics. FIGO, according to FIGO, carbetocin, one of the recommendation for PPH management. Germany, Austria, Swiss body, carbetocin 100 UG, slowly IV. France, FCOG, carbetocin on providing non-inferior to oxytocin. My experience with carbetocin: case 1, patient name XYZ, age 32, patient with risk factors for PPH such as prior cesarean, multiple pregnancies, and preeclampsia were enrolled. Outcome where the carbetocin was associated with significant decrease in the occurrence of PPH compared to oxytocin in this high risk group. It also reduced the need for escalation of therapy to resolve bleeding. Okay.
Thank you very much, madam. Madam, in this case, what was the route of administration?
IV.
IVU.
Yeah, yeah.
And essential reason was that the patient has a high risk factor, especially multiple pregnancy.
Yes, yes,
So
yes.
possibly the tone of uterus would have been less.
Hmm.
And again, she was a high risk patient because of a cesarean.
Yes, yes.
Some of the questions, madam.
Huh.
What is the patient profile where we can expect PPH?
There are some in some pre-existing condition like previous history of PPH, multiple pregnancy, yeah, uterine abnormalities, coagulation disorders. If
Okay.
a patient is pregnant, then placenta previa, polyhydramnios, macrosomias. There are so many conditions we can use it.
Yeah.
In.
In fact, PPH, we hope we don't get. It's a good topic to discuss, but very bad to handle. I
Yeah,
mean, it's a, yeah, yeah, yeah. And patients with fibroid also may be a little more at risk, I suppose.
Yeah. Fibroids, we can use it in that also.
Yeah, but it would be the patients would be at more risk, I suppose, to get PPH because of
हाँ,
the
yes.
yeah
हाँ, there's a uterine contraction अच्छे से नहीं होता.
contraction would be affected. Can we use carbetocin in case of retained placenta? Of course, after removal of placenta.
The
Any
main
experience?
primary treatment is not to stop the bleeding. The primary treatment is to remove the retained product in it. When we remove
Correct.
the food, then we can use it. No problem.
Uh, So only after removal of
Yeah.
retained products. In RH negative mother, madam, you will have an experience.
Yes. Of course, you can use it. Its mechanism of action and effect are not related to RH blood group. You can, of course, use it.
If a doctor uses oxytocin for labor induction, many of them would be using augmentation induction. Can they use carbetocin for prevention of PPH?
Yes, you can use carbetocin is synthetic analog of oxytocin itself.
Okay. So there's no harm in using, even if oxytocin is used.
Carbetocin acts on oxytocin receptors.
Okay.
But difference is carbetocin prolongs the effect and provides sustained uterine
As
contraction.
compared to oxytocin.
Yeah.
You generally use, since how long you have been using carbetocin, madam?
Not, I think maybe 1 year or less than that.
Okay. And you generally prefer which route?
IV.
IV route.
Yeah.
Do you have any place for IM route?
Yeah, I am also, है ना? But
Ah,
for immediate action, I use it IV. It
so
is safe to do IV both routes.
yes. Any specific cases where you would prefer IM route, especially for the audience?
In IM when we use for a prolonged effect, actually it works for 2 hours, but with
Ah,
IM it works more than that even.
okay. So where you require a prolonged duration of effect, you would prefer IM route.
Hmm.
And where you prefer a faster onset of effect, you would prefer IV route.
Yes, IM.
Yes. Is there any deadly complication of carbetocin, severe side effect
I have not seen
that
yet.
you have experienced?
No, I have not
No.
yet.
Thank God.
I have benefited. I have not.
Yes, good. That is great. Now, this is if patient is not responding adequately with carbetocin, which can happen, then what next? Whether the
Uh,
dose can be repeated or whether additional uterotonics you would use.
those can be repeated, and other options are also there, like misoprostol, uterine balloon tamponade, and all carboprost. Yes, we can use. When this will not work, then we'll go for surgical procedures.
Of course. Surgery is the last resort.
Yeah.
But, madam, do you repeat the dose? Have you
Yes,
repeated dose?
can we can repeat the dose.
Okay. What are the specific advantages, madam, of carbetocin you feel over other uterotonics?
The specific advantage is single dose administration,
Yes.
है ना? Longer half life,
Uh,
rapid onset of action, prolonged effect up to 2 hours,
that is very
sustained
important.
uterine
Yes.
contraction, and the most important, no need of refrigeration.
Which is very
It's
important in our country with power
and
outage. Yeah. Even in city like Mumbai, big cities also power outage is common. And especially this factor is important in the interiors, the single use can be given IM or IV, even the periphery.
Hmm.
Yes, these factors would be very important, I suppose. But madam, sometimes what happens, doctors, they know all the benefit of carbetocin, but still somewhere there's a hesitation in terms of usage of carbetocin.
No, maybe from cost effective, maybe.
Cost, yeah,
Yeah,
cost is a factor.
yeah.
No, maybe, yeah. Because,
But there is so many benefit we can go for it.
yes,
Yeah.
which is the same thing question I was asking. Many doctors keep it as a reserve drug rather than using as a first line.
No, you can use at a reserve drug, but not a first line. Well, if you can use it in first line when there is a history of PPH, yeah, there is anomaly of
Correct,
this.
correct.
You are knowing that this patient will land up in PPH, then you can use it as a first line.
So those patients who are prone to get or who are likely to get PPH, it should be used as the first line.
Then you can use it first line.
First line. And if carbetocin fails, it is a myth. If carbetocin fails, then no other drug can help. Is it true?
Yes, it is true.
It
Then
is
we go for
true.
tamponade. Yes.
Then nothing helps.
No, we try it, but I don't think it will help more. We will go for balloon tamponade and then other procedures.
Oh, so
Meso.
if
We
carbetocin
have done
fails,
all
then no other pharmacological drug helps. So you have to
that.
go for
Yes.
physical measures, you have to go for surgery. Okay. Is there the role of anesthetist vis-a-vis gynecologist for choosing a drug for prevention?
Yes, there is a rule when I'll choose it for the first line treatment.
Huh,
Then patient is also benefited,
correct.
and I'm also benefited.
Yeah, yeah, yeah. If drug acts fast and it's a life-saving measure, no?
Yeah, yeah.
The potential risk is, we have to take the patient to surgery.
Hmm.
Yes. Now, if I have to conclude your overall experience, you have to take home message to the audience.
If the patient comes with a history of PPH, yeah, if you know that she is going to land up in the PPH, then you should use this. It's a very good drug, and it's a good half life. So you result is very good. You can use it to save the life.
Yeah. Thank you so much, madam. Thanks for your
Thank,
time.
thank you so much.
Yes,
Thank you.
thank you so much. And thanks all the audience who took time from their schedule and attended this meeting. Thank you, marketing team. Thank you, IT team, and thank you, sales team of Wipro for super coordination and support. Thanks all of you. Wish you a very pleasant evening. You can sign off, madam.
Okay, thank you.
Yes. Thanks, Nagadevi. Thanks, Bivas.
Thank you, sir.
Thank you, sir. Thank you so much.